everyone, dear audience, dear chair. I'm really happy to be here to present you my PhD thesis, which is the strategies in coronary artery bypass grafting in patients with acute myocardial infarction. My name is Judit Liebermann. I'm a first-year PhD student. I graduated at the Medical University of Târgu Mureș in Romania. I'm at the Department of Cardiovascular Medicine and Research. My supervisor is Gábor Durai, and my SMS is Nina Galdzicka. My vision is to provide the highest standard of care for patients with acute coronary syndrome. And my mission is comparing the outcomes across different strategies. My specific goals is that investigating of the optimal timing of coronary bypass grafting and also investigating the effect of BMI in open heart surgery patients. I started broad projects in this autumn. So my first project is investigating the optimal timing of coronary artery bypass grafting in patients with acute myocardial infarction. With myocardial infarction. So acute myocardial infarction is one of the leading causes of mortality in the developed world, with across like 3 million cases per year. CABG is an essential surgical intervention to restore blood flow. We have to compare the risks of early and delayed surgery. Our aim is to determine the optimal timing for CABG in order to improve the clinical outcomes. So both early and late CABG, as I mentioned, have advantages and disadvantages. For instance, the early CABG comes with improved revascularization and also reduces the size of the infarction, but can cause increased perioperative risk and also increases the risk for the development of cardiogenic shock. For late CABG, we have decreased perioperative risk, and since we leave time for patients, they will become hemodynamically more stable during this time. And also we leave time for the myocardium to recover from the necrotic areas. But it comes with increased risk for recurring ischemia, heart failure, or even sudden cardiac death. So our clinical question is, what is the optimal timing for performing CABG in patients with acute myocardial infarction? My framework is a PFO1, where the population is the myocardial infarct patient who are undergoing a CABG intervention. Our focus is on the different timing for CABG interventions, and the most important outcomes are mortality, postoperative complications, and length of hospital stay. The hypothesis is that early CABG in acute myocardial infarction patients is not inferior to the late intervention. So this is the final search key that were conducted in 3 databases, and it's divided to 3 domains. The first one is focusing on the myocardial infarction. The second one is focusing on CABG intervention, and the third one is on the timing. So those are my key articles, which present pretty much the similar outcomes that I included. And also in the additional comments part, you can see that there is still no understanding or, agreement whether the emergent or the delayed CABG is more safe and effective. That is the preliminary search key that which I found my key articles with. And flowchart selection, I had more than 10,000 records before the duplicate removal. And after that, I finished with 7,000. So that's how my first project is at the moment. It passed the feasibility check and we registered on Prospero. I'm done with the duplicate removal and the title abstract, as my dear co-investigator mentioned. Bernie, we finished her project, and mine is also more than 50% done, so I think we will finish pretty soon. My second project is investigating the effects of BMI on postoperative complications in patients who are undergoing open heart surgery. So the global prevalence of obesity has nearly tripled from 1975 to 2021. In 2021, 39% of the adults were classified as either overweight and 30% as obese. Obesity significantly increases the risk of coronary artery diseases. So individuals who have a high BMI, 30 or above that, have a 64% higher likelihood of developing coronary artery disease compared to those with a normal BMI. Obesity further complicates surgical care patients who are facing an open heart surgery. Our aim is to investigate how obesity influences the postoperative complications and recovery in open heart surgery patients. Our clinical question is there a higher risk of postoperative complications in patients with extreme BMI values? I also used here a PFO framework, where the population is patients who are undergoing open cardiac surgeries. The focus is on BMI, and outcomes are postoperative complications, atrial fibrillation, wound healing, and mortality. Our hypothesis is that patients in an extreme BMI, which is either underweight or overweight or even obese patient, have a higher risk of postoperative complications following an open cardiac surgery. Yes, the clinical and research implication is personalized pre-operative care risk stratification and planning and management for the long-term outcomes. The preliminary search key, I here introduced two domains, one as the cardiac surgery and the other one is BMI itself. It has also been conducted in 3 databases. These are my key articles. They are also similar to my outcomes, and we have to compare that, as it mentioned here, that how so it's the terms, remain uncomparable for now. And I would like to summarize that I hope and plan to finish both projects during this summer or September, the second one. And I would like to finish with a quote from Albert Einstein, that all of science is nothing more than the refinement of everyday thinking. Thank you very much for your attention.
Thank you for the nice presentation. Girls first.
Thank you for your presentation. It was really nice. And I would like to ask, why is wound healing modified in extreme BMI patients?
Thank you very much for this question. In overweight patients, it's modified because they have a more poor immune response than as a normal weight patient has. They also has a reduced collagen production, and since obesity comes with a chronic ongoing inflammation, this process is also exacerbating this healing. In underweight patients, they are malnourished and they have a reduced vascular supply. So that's why it's complicating. Thank you very much.
So first of all, congratulations on your presentation. It was really nice. I would like to ask that in which cases or scenarios is the CABG is chosen instead of PCI?
So in cases where, for instance, there is an ongoing ischemia or the PCI has failed or there is a mechanical complication, like either mitral regurgitation or ventricular septal rupture, or also in these cases where there is a multivessel involvement or the left main coronary artery is occluded. Thank you.
Thank you. Then the right side, please.
I just wanted to ask, what is the current recommendation for revascularization after acute myocardial infarction?
So for STEMI patients who have symptoms less than 12 hours, it's PCI, the percutaneous coronary intervention. And all the other cases that I have mentioned before, or when PCI fails, that's when CABG is chosen. Thank you.
So thank you for your presentation. I would like to ask, do you plan to make any subgroups based on the type of the vessel you use at the surgery, like venous or arterial graft?
Yes, I was also thinking about this. Yes, I am planning to do subgroups.
Congratulations. My question is regarding to your second project. You mentioned that patients with extreme BMI, they can develop more serious complications. What kind of complications would you expect, and how do you address these patients?
So most commonly, as I mentioned, wound healing and renal complications, respiratory complications, also thromboembolic events like deep venous thrombosis and pulmonary embolism can happen. Also, obese patients tend to have sleep apnea or pneumonia, which also exacerbates their situation after open cardiac surgery. Yeah, and cardiac problems, atrial fibrillation is also more common, and respiratory failure, acute kidney injury, and the wound healing also.
Thank you.
Thank you.
Thank you for the nice presentation. Apart of the timing of the CABG, what other factors could influence the outcome?
I'm sorry, can you, what the factors?
Could influence the outcome.
Okay. Well, it's the state of the patient, how is the condition of the vessels, and how is the myocardium's state at the current operating phase.